An anti-CD3 antibody Teplizumab in relative risk for type 1 diabetes. Introduction. Type 1 diabetes is a chronic autoimmune disease that leads to destruction of insulin-producing beta cells and dependence on exogenous insulin survival.
Type 1 diabetes is a condition in which the pancreas produces little or no insulin. Insulin is a hormone that helps your body use blood sugar, known as glucose, for energy. Your body takes the food you eat and breaks down fat, protein, and carbohydrates for energy. While your body is digesting the food, the carbohydrates are broken down into glucose. The glucose is then absorbed into the bloodstream, where it is carried to cells throughout your body. Insulin helps your cells absorb the glucose in your blood, allowing it to be used as energy. A healthy pancreas releases a regular supply of insulin into your bloodstream. After you eat, your blood glucose levels rise, and your pancreas responds by releasing more insulin to move the glucose into your cells. Insulin acts as a key, opening up the cell so it can accept the glucose. In a person with type 1 diabetes, the pancreas produces little or no insulin. Without insulin, blood glucose levels rise. Without insulin, glucose cannot enter the cells and be used for energy. As a result, it remains in the bloodstream. As a person with type 1 diabetes, it is important to monitor and maintain healthy blood glucose levels. High blood glucose levels over a long period of time can lead to health complications. If your blood glucose level drops too low, even for a short amount of time, you may feel dizzy or too hot or cold. If your blood glucose level drops extremely low, you may lose consciousness. By taking insulin as prescribed by your doctor and maintaining a healthy diet, you can keep your blood glucose levels within a healthy range.
Application in medicine. We conduct a phase 2 randomized placebo-controlled double-blind trial of Teplizumab, an Fc receptor non-binding and anti-CD3 monoclonal antibody, involving relatives of patients with type 1 diabetes who did not have diabetes but were at high risk for development of clinical disease.
This is Christina Fiore of MedPage Today, reporting from the ADA meeting in San Diego. In type 1 diabetic patients, Teplizumab didn't improve glycemic control or lower insulin dose, according to early findings of the Protégé trial. But during a press briefing here, senior author Dr. Nicole Sherry of Massachusetts General Hospital said the monoclonal antibody may preserve beta cell function.
The primary outcome did not differ among groups at 1 year. In the 14-day full-dose group, 19.8% met the composite endpoint at 1 year, compared to 20.4% in the placebo group, so about equal. However, importantly, exploratory analyses suggest that the 14-day full-dose regimen preserves C-peptide with a P of 0.046 at 1 year. Additionally, 5% of patients did not require insulin at 1 year in the Teplizumab groups, with no patients off insulin in the placebo group at 1 year, with a P of 0.03. In addition, the percentage of patients requiring very, very low doses of insulin, doses of less than 0.25 units per kilo per day, and retaining glycemic control with an A1C of less than 7%, was greater compared to placebo at 1 year, with a P of 0.006.
Certain subpopulations may garner additional benefits.
We notice particular benefit in children ages 8 to 11 years. And this is an important finding because the management of diabetes in children is very challenging, with higher rates of hyper as well as hypoglycemia. As well, also, patients who began treatment especially early, so within 6 weeks of diagnosis compared to within 12 weeks for the whole population, also had a greater benefit. Lastly, we noticed regional differences, with patients in the U.S. demonstrating a greater treatment effect.
Sherry also emphasized that the therapy was well tolerated.
Across the 4 study groups, a similar proportion of subjects experienced adverse events, 99% in the teplizumab groups versus 99% in the placebo groups. And the same rate for serious adverse events, 10% in the teplizumab groups versus 9% in the placebo groups. The most common clinical adverse event in the teplizumab groups was rash, 53% in the teplizumab groups versus 20% in the placebo groups. It was generally macular-papular, often pruritic, and self-limited. We also saw transient decreases in white cell counts, especially lymphocyte counts. However, there was no significant decrease in infections across the groups.
Dr. Sherry said the findings suggest that there is indeed a biological effect of teplizumab in this population, and it may be best for certain subgroups, like children and the very recently diagnosed. At the ADA meeting in San Diego, I'm Christina Fiore, MedPage Today.
Pros and cons. Pros. The percentage of participants with progression to clinical type 1 diabetes in the overall trial population was greater in the first year after trial entry. Cons. Anti-CD3 monoclonal antibody treatment has been associated with Epstein-Barr virus reactivation.
This is Miriam Tucker reporting from the American Diabetes Association. I'm with Dr. Jay Schuyler. Dr. Schuyler, there are several approaches being looked at to prevent type 1 diabetes. How would you characterize the state of the field in 2011?
Well, really, Miriam, the issue is that we've been testing things in new onset type 1 diabetes to see whether or not they modify the course of the disease and to gain insights as to which ones are safe enough to take into prevention, which is the question you've asked. And what we've learned is that some of them don't work in new onset diabetes, but they are safe. So they might work earlier in the disease process for prevention. So the fact that they haven't worked in new onset doesn't mean that they shouldn't be used for prevention. And whether we need a combination of things to really arrest the disease process is the other open question. And so we've got to take all the information and really try to say, okay, where does that leave us now? And to me, it says that we still have a number of promising things to look at. We still are not happy with the way some of the results have turned out because we think trying to help people with new onset disease would be useful too. And so I think the field is in a state of flux at the moment. And we're going to have to go process all of these things and try to say, where does that lead us for the next round? And the next round may be combination things in new onset first, but then we have regulatory issues to deal with. And we also have to convince potentially different manufacturers to get in bed together to give us medications we want to put together, and they may not be interested in that. So the challenge is for those of us who are trying to understand this better and really dissect the disease process, find out ways that we can alter it, is going to go on for a while as we try to do things to sort it out.
Are you optimistic about the future?
Oh, I am, because I think all the things that we're learning are little pieces that come together. You know, it's the same way you reporters tell stories. You get today's news, but in the end, somebody's going to sit down and write the book about all the stories that went on. Or, you know, if we're dealing with, for example, the war in Afghanistan, you're going to report each day's events, but at the end, it will be over, and we'll be able to go back and put it all together. I think that too many times audiences hope that today we're going to have the headline that really changes the whole course of things, and it doesn't work that way. We make steps progressively over time, and I think we've made lots of good steps where we've learned a lot of insights, and that we're going to continue to make progress. And I hope in my lifetime we are going to lick this disease.
Where do you think we'll be in 5 years?
I think we'll be farther along than we are now.
Thank you.
I don't try to put time frames on things.
Thank you so much, Dr. Schuyler. This is Miriam Tucker reporting from San Diego.
Issue in Ecuador. There are not epidemiological data in Ecuador about this treatment. According to the data from the Ministry of Public Health, there are up to around 2,200 patients 0 to 14 years diagnosed and insulin dependent, while in 2013 there were about 18,000 restricted.
This is a research product available from the antibodies.com range. For more information about this product, including how to order it, see the link in the description. Visit antibodies.com to discover this and more quality life science research products.
Conclusion. In conclusion, in our trial, a week course of treatment with Teplizumab delayed the diagnosis of clinical type 1 diabetes in high-risk participants.
Researchers are developing a new prevention method for type 1 diabetes in children. Doctors have discovered a method to identify children most likely to develop type 1 diabetes, providing them with medication long before signs of the disease are apparent. 76 children were involved in the Melbourne-led international trial, with researchers using an experimental immune therapy to delay the disease by 2 years. It's hoped the research will prevent, slow or halt the onset of type 1 diabetes in kids.